Check. name on IAS CME Madurai.
Okay. Yes, sir. நிறைய லேப்டாப் தான் சார். அதுதான் பார்த்தாச்சு சார். ஏஎன்எஸ் சார் கேபி சார் என்ன தெரியல. பென்ட்ரைவ்ல இருந்து பண்ணிடலாம். அந்த அவருக்கு மட்டும் அதுல இருந்து பண்ணிடலாம். கொஞ்சம் லோட் ஆகுது சார். சரி ஓகே. பேக்கப் வச்சுக்குவோம். இங்க ஓபன் வச்சுக்குவோம். இதோட டக்கு மாத்திக்குவோம்.
இந்த ஸ்லைடு இது போடுறோம் இல்ல சேர்பர்சன் இது போடுறோம். ஓகே. Good morning, respected faculty, delegates, and one and all. So I thank Sundarajan sir, Tapasvi sir for giving opportunity for Preeti Hospital to host this Indian Arthroscopy Society Outreach CME on arthroscopy. And we thank for selecting Madurai and Preeti Hospital sir and giving us opportunity to do this event here. So I welcome all the delegates who have come from various parts of southern India, and also we are going this live. So there is a registration from Pakistan, Maldives for the online this thing, sir. So definitely we have a broader reach through online for this event. So we will start sharp on time. So without spending more time, I'll just, we have two sessions, two didactic sessions, two live surgeries, and we will have a workshop on meniscus repair. So first is a session on ACL and meniscus. So for which I would invite Professor M. Chidambaram sir. He is the head of the department of Preeti Hospital, orthopedic department, and Dr. Satyanarayana sir. He is President MOS Madurai Orthopedic Society, and also unit head at Madurai Meenakshi Mission and Research Center. So these, I welcome chairpersons to moderate the first session, sir. Sir.
Welcome to this wonderful session of arthroscopic meet organized by Preeti Hospital. I thank the organizers of Preeti Hospital giving me this opportunity to chair this session and start the ball rolling on. And I also thank the Indian Arthroscopic Society for choosing Madurai as the venue. And to start off, this is a very interesting and a very important session of ACL and meniscus injuries, which has become very common. I'll start off by calling up Dr. Jyoti Prasad from Gem Care Hospital, Kannur, to give a talk on classification of meniscal state and how to identify them arthroscopically. Dr. Jyoti Prasad.
Very good morning, one and all, respected seniors and my dear friends. I am here to talk about a classification of meniscal tears and how to identify them arthroscopically. And I'll be just running through basics of meniscal anatomy and how to see it arthroscopically. Basically, we know the meniscal tears are the most common soft tissue injuries of the knee joint. The traumatic meniscal tears are most commonly occurring in young active people during the twisting sports such as football and basketball. Degenerative tears commonly occur in patients with osteoarthritis, although the exact incidence and prevalence are not known. So the anatomy, there are two fibrocartilaginous crescents, as you know, the menisci which are seen, which has two ends, two borders, and two surfaces. The medial meniscus is a C-shaped structure forming 3/5 of the ring. The anterior horn is attached to the tibia, anterior to the intercondylar eminence of the anterior cruciate ligament. Posterior horn is attached immediately in front of the attachment of the posterior cruciate ligament, posterior to the intercondylar eminence. You can see the attachments. And this is the medial meniscus. The peripheral border is attached to the medial capsule and through the coronary ligament to the upper border of the tibia. So the medial meniscus is more attached to the surrounding structures rather than the lateral meniscus, which is more free. Most of the weight is borne on the posterior portion of the meniscus. And in the lateral meniscus, the most important thing is that it is a circular. It is forming the 4/5 of the ring with the symmetrical anterior and posterior horn. Mostly it converts convex to convex area, that is from the femoral and the tibial surface, both are convex. So if the lateral meniscus is torn, it is very important to repair it, because if you take it off, it will create a very huge stress riser in the lateral aspect, because it is covering 4/5 of the surface, and it is also converting convex and convex areas into a more congruent areas. The anterior horn is attached to the tibia in front of the intercondylar eminence, and the posterior horn is attached to the posterior aspect of the intercondylar eminence in front of the posterior attachment of the medial meniscus. See that the lateral meniscus, you can see in the posterior horn, it receives anchorage to the femur through the ligament of Wisberg. That is pointer. Here you can see that the posterior horn of the lateral meniscus, it is attached. This is a posterior menisco-femoral ligament. That is the ligament of Wisberg, and anteriorly there is a anterior menisco-femoral ligament. Anterior meniscofemoral ligament and posterior meniscofemoral ligament both are attached to the posterior aspect of the lateral meniscus, and it goes along with the PCL and attaches to the medial aspect of the femoral condyle. The tendon of the popliteus separates the posterolateral periphery of the lateral meniscus from the joint capsule and fibular collateral ligament. The blood supply, as you know, the menisci of the knee develop at 8 weeks of gestation as a collection of fibroblasts. At birth, the menisci are vascularized through their substance. With aging through early childhood, there is eventual peripheralization of the vascularity. That is, initially only the entire thing is vascular, but later on only the outer portion is vascular. So here you can see the peripheral blood supply, that the perimeniscal plexus is there, comes from the inferior genicular artery, and it gives synovial and capsular tissue periphery, supply the peripheral border of the meniscus. So depth of the vascular penetration is 10% to 30% of the width of the medial meniscus, and it is 0 to 25% in that of lateral meniscus. So here you can see the red zone, red-white zone, and white-white zone. The periphery, it is totally vascular. In the middle, there is a red-white zone and the white-white zone. So there are several classifications of meniscus. Mainly it is an O'Connor classification, which classifies the meniscal tears into a longitudinal tear, a horizontal tear, oblique, radial tear, and many other variations. So a longitudinal tear, as you can see, there are 4 basic patterns. There's type 1, it is a longitudinal tear. It divides the meniscus into an inner and outer portions. See that there is a meniscus is torn longitudinally. In a horizontal portion, it divides into a superior and inferior one. Then the oblique one is the this one, it is oblique tear over there, and a radial tear. A radial tear, if it extends peripherally, it is akin to nearly a total meniscectomy type of tear. And this is a longitudinal tear. You can see that we are pulling it to the probe, and the longitudinal tear is visible here. This one is a horizontal tear, in which you can see an upper flap, which is the femoral aspect, and lower one in the tibial aspect. So there is a horizontal tear associated with meniscal cyst, as the fluid can seep out and cause meniscal cyst. It's a radial tear. You can see that it's a complete radial tear. If it goes to the periphery, it divides the meniscus entirely and it will cause a loss of the hoop stresses and it will account to a near total meniscectomy. Sorry, it will just be like a meniscectomy because there is a complete radial tear. It has gone to the periphery. And this is a flap tear or other degenerative type of tears in which a flap of the meniscus is torn. In complex tear, it accounts to almost all the tears together. That is, it's a complex type of meniscal tear. And this is a degenerative tear. You can see the degenerated meniscal tissue there. It's completely degenerated and it is torn out. So another one is a ram lesion. The ram lesion were less identified earlier, but now we should look for the ram lesion. Then only we will find it out because nearly 18% of ACL injuries are associated with the ram lesion. Capsular tear. You can see that it is a ram is the area in which the meniscus and the capsule attaches to each other. It's a sliding area. That's a ram. So at this portion, you can see the tear. So this is a type 1 tear. Type A, B, C, D. You can classify it. The type 1 tear is a meniscocapsular ligament region tear. Second one is here. You can see the meniscotibial ligament. The classification is in a type 1 is a meniscocapsular tear. The type 2 is a partial superior tear. That is only the partial portion or the superior aspect is torn. Type 3 is a partial inferior tear. That is in the inferior aspect it is torn. And type 4 is a complete tear. And type 5, you get a double tear. So this is a partial superior one. This is a partial inferior one. And this is a type 4. There is a double tear. That is 2 types of tears are seen there. And another one is a meniscal root tear. That is, meniscal root is defined as an area which is nearly 1 centimeter to the root of the meniscus attached to the posterior aspect of the bone. Here you can see a type 1 is a partial root tear. Type 2 is a complete root tear. That is a radial one. The radial tear extending just beyond, just at the region of 1 centimeter at the root is called a root tear. So type 3 is a complete root tear with a bucket handle tear. Type 4 you can get an oblique tear, and type 5 is a root avulsion fracture. So arthroscopically, what you can see, just I have taken a small video. In this video, you can see that you should look for tear. Then only you can find many of the tears. So just a diagnostic arthroscopy with probing will be very efficient. So it's a lateral meniscus you are seeing there. You are pulling the popliteus tendon over there. The mobility you are checking it, and the medial meniscus, as I earlier told, you go for the posterior aspect of the lateral meniscus. All the medial meniscus and lateral meniscus, you are pulling it. And again, this is a looking for the ram lesion. So that is very important. You should look for the ram lesion, otherwise you will never find it. You go through the posterior medial portal, putting the probe there, and you are elevating the meniscocapsular region there. You can see that you are seen through the posterior medial portal. This is the view through the posterior medial portal. See that you're going between and you're going behind the knee, and you're putting a probe there, and you're elevating the region of the ram. You're looking for the ram lesion. Then only you can see it, because it will be hidden there. And in this, you're probing through the posterior. Probe is coming through the posterior medial portal, and you're trying to elevate that region. And here you can see the ram lesion clearly. Here you can just pulling it through the medial meniscus posterior horn, and that is a gap there. That is a ram lesion you're seeing there. With the probe, you are pulling it. In this, you are not using the posterior medial portal. You're just coming from there. And these are the type of meniscal tears. It's a horizontal type of tear seen in the medial, in the lateral meniscus there. This one is a root tear. The root is avulsed from the medial meniscus. You can see the root. It is avulsed from there. And you are trying to fix it by drilling there, and this root is totally avulsed and it is floating. It can floating there. And this is another one. It's a bucket handle tear. The entire tear is gone, and it is in the intercondylar notch. You are freshening it up and trying to fix it. So this is a bucket handle tear. And this is a complex type of tear, in which there is a horizontal component and also a flap component. This is another horizontal tear, which we are probing, and then only we will see the undersurface of it. So this is how we put a posterior medial portal. It is just described. You are going in between the PCL and the medial condyle, and this triangle region, you are going, your scope is going inside. You are seeing the transillumination in the medial region, and you're putting a needle there, and you're putting a portal there. So this is how you assess the posteromedial portal and to assess the ramp lesion there. So it's a short video. So this you reach the posteromedial region, and from there you can put a posteromedial portal and see the further ramp lesion. So you put a knife there, and the instrument is going in. So this is a posteromedial portal placement. Okay. So this was just a short video about that. So thank you for the patient listening. Thank you.
Thank you, Dr. Jyoti Prasad. Now I call upon Dr. Sundarajan to give a talk about overview of various methods of meniscal repair, when and how to do it. I welcome Dr. Sundarajan to give a talk on overview of various meniscal repair techniques.
Good morning, everyone. So my topic is about meniscus repair technique. So I will show some 3 or 4 cases where how to do the repair techniques in indications. So how to get a successful repair depends upon how you choose the patients. The right indication is the most important thing by choosing the meniscus repair. Of course, you should have the armamentarium of implants and instruments, because sometimes MRI, you cannot predict how much suturing you require, how much implants you require may not be evident by seeing the MRI. So you should have all the armamentarium in your theater, and you should explain to the patient also the cost wise, it will going to make a difference, because we cannot say a fixed price for a meniscus repair technique. And also the techniques, which is very, very important. You should learn all the techniques before you start your ACL practice, because ACL surgery is not just ACL surgery. You have to address the cartilage and meniscus. So when you see a meniscus which has to be repaired, then you should do a repair. So it is important that you learn all the techniques before you start doing the arthroscopic ACL reconstruction, not the meniscus. So not all the tests are symptomatic. That is also very, very important, because you know all the techniques. You cannot institute all the techniques for all the meniscus repair. So the indications for the meniscal surgery is very, very important, because you can see asymptomatic tears in the MRI. So it doesn't mean that patients require any meniscectomy or a meniscus repair. So make sure that you correlate the clinical symptoms, history, then MRI. Then you choose that indications to do a meniscal surgery. When you do an acute tear, again, most often this meniscal tear are associated with other meniscal injuries, like other ligament injuries, like ACL or a PCL or a multi-ligament injuries. And you should assess the age of the patient, zone of the tear, where you know that you have to repair in a red zone or a red to white zone. At the same time, when you see a complete tear, then you should be able to repair even whether it's in spite of any zone. That is also very, very important. When it comes to the type of tears, I will show in the cases. In chronic situations, the most common situation which you come across is the bucket handle tear. So the most important assess in a chronic acute situation up to, of course, you repair in a white red zone and a red white zone. In a chronic situations, if you see a bucket handle tear in the same zone, it is important to assess the quality of the meniscus. Reducibility of the meniscus will decide whether they require a meniscus repair or a meniscectomy. If you are able to reduce it well, the meniscus go and sits very well in that place. That means you have to repair that meniscus. So of course, the root tear and horizontal tears comes in the chronic situations. Radial tears, these are all the chronic tears requires a repair. I think Dr. Palnivel is going to show the indications. When you want to do a meniscus repair, the most important technique to learn is the pike resting. So this is very, very useful technique to not only just to do a root tear, any bucket handle tear. If you are struggling, do a pike resting, make the middle opening little bit more, 3 to 5 mm more, so that you don't damage your cartilage. So that under your technically, it is very, very easy. You can see how the space is opened up when you do a pike resting with the 16 gauge needle from the outside. You can do it in both tibial and femoral side. So this is the case of a 7 years duration of pain and instability. This patient had a Lachman's and anterior triad positive. He has got a pain on the medial side too. So when you go inside, there's a peripheral tear of the medial meniscus. That's what I said. That even there's an old ACL tear, patients can have a recent meniscal injury. So it is important that you expect this kind of injuries and go inside, because you cannot tell the patient that there is a meniscal tear because 7 years I do a meniscectomy. You can see this is almost in the meniscocapsular junction. So in this case, we cannot do a meniscectomy. That means you are going to do almost a subtotal meniscectomy. That is very harmful. So in these cases, so you have to do a repair. So you can start with the inside out stitches. It is very important armamentarium for your any meniscus repair. You do a first one mattress stitch, then you can do a vertical stitch that is next to that. So you can alternate that mattress and the vertical stitch is very, very important. So this is the vertical stitch which you make one in the meniscus, one in the capsule. So these alternate stitches adds the more stability to your meniscus repair. And I'm not able to do the, okay. So this is the, so once you finish the superior surface, then you come to the inferior surface. That is also very, very important, because we cannot just plan your suturing on the superior surface. Once you do a superior surface, you can see that the meniscus is flipped off. So you should make then suturing on the inferior surface too, both the vertical and the mattress stitches, so that at the end of the both superior and inferior surface, your meniscus gets stabilized in this position. So that is the inferior surface suturing. So this is again the inside out technique. You can see that once you put the inferior surface, it gets balanced. Then finally, once you do that posterior horn, in the middle horn, then you go to the posterior horn. Here you use the all inside technique, which is available with commercially available with all the companies. So here you are using the fast fix. That is then because here I didn't do a pike resting. If you feel very tight space over there, do a pike resting, open up bit so that you are passing the instrumentation easy. Otherwise, you will spoil the instrument, which is around 20,000 rupees one instrument. Sorry, one implant. So it is important to do the pike resting. So this is how this all inside repair works, where the two implants go back of your meniscus and flips over there. That holds that meniscus. Then you pull that threads, then that tighten up, the knots gets tightened up and gets the stable meniscus. So in this case, you can see you can use the mattress and vertical. You can use oblique also, oblique tears that adds the stability to the repair. You should use both the superior and inferior repair. And most of the time you require an all inside when it is extended to the posterior horn. So suspect new meniscal injury even in the old ACL. So this is another case, 29-year-old old male patients, pain and DVT for 3 months duration. That is the X-ray, that is the MRI. You can see that is the pectinal tear. That is the double PCL sign, which is the evidence of pectinal tear. You can see this case, this is the posterior horn of the, whole pectinal tear was the joint that was adherent to the ACL. So in this case, you separate that ACL adhesions between the adhesions and the meniscus. Cursor doesn't work. Cursor doesn't work. Okay. So you can see this, you prepare the meniscus. That's very, very important. You use your sharp shaver, or you could use the meniscus ramp to prepare that meniscocapsular junction. Sometimes you can have the small comminuted fragments where you can take off before you move on to the repair. Then you reduce it, then you stabilize the meniscus by using the inside out technique. That is most important. You can see the reducibility of the meniscus doesn't look like very great, but it's only a 3 months duration. But it is almost a red-white zone or red zone. So here we cannot do the subtotal meniscectomy. So you can see that after preparing, putting the meniscus inside, then you do the inside out. That is the easy way of stabilizing the meniscus. So once you do the reduction, then you do the inside out technique with 1 or 2 stitches like this. So that will give you good stability of the meniscus. Then you keep on adding your vertical and mattress stitches like this. So you may require at least you require a 5 mm gap. We can use a 5 mm gap between each repair technique suturing. So you cannot give a long gap also because you need a both stability for a bucket handle tear. So you may require to do a 6 or 7, 4 or 5 on the superior surface and 4 or 5 on the inferior surface. That's how you stabilize the meniscus. So then you take out the stitches. You don't need to do a posteromedial safety incision. Of course, you can do a posteromedial safety incision if you want to avoid a nerve injury. But if you are very careful, then you can see the most of the stitches are coming out not in the posteromedial surface. If you are take care of your positioning when you take it out. So that is, then you add an outside in technique for your anterior horn. So that is how you posterior horn of the you see the once you finish the middle horn and the anterior horn, then you see still the posterior horn is unstable. So that has to be added with both the superior surface all inside technique and the inferior surface. You can see that one pass fix going on the superior surface, one goes on the inferior surface. At the end of the procedure, then you do the you see the stability, then you do the ACL reconstruction. You can add a microfracture or a PRP or a bone marrow aspiration, which I don't do, but when you have an isolated meniscus bucket handle tear, you can do that. That was the final repair. You can check it in the both flexion and extension that found to be very stable. So this case, on next two cases, I go quickly. This is an 37-year-old patient. You can see the complete radial tear, which you see in this kind of ACL tear with the radial tear, which is one of the common scenario. Whenever you see an ACL tear, the most common scenario is the posterior horn, the lateral meniscal tear. So when you see a tear like this, you think that we cannot do the repair because it's completely torn and separated. But you can do the repair of this meniscus. You can do you can see that I'm being through the anteromedial portal, working through the anterolateral portal. So this kind of these instrumentations, which you do it for a shoulder, we have for the knee also. You can use the side to side stitch. So that helps you to approximate this both the fragment and get along with each other. Then you change the scope to the anterolateral side, then work through the anteromedial portal. So I'm taking another bite through the middle horn. So the first bite was taken through the posterior horn. Then you take the side to side stitch. Then you approximate the meniscus. So that is how it looks. You can see the securing with your sliding knots, which you use for the shoulder. So that approximate the meniscus. The lateral meniscus posterior horn has got a good healing potential. So you don't need to worry about the healing issue. So again, that was added with an all inside stitch. Then again, you add in a second side to side stitch. So that adds a stability to the repair. So one repair may not be sufficient, one stitch may not be sufficient. So use 2 or 3 side to side stitches. And then at the end of the day, you see that is the final repair. That the remaining inner edge can be trimmed off. Just you can use like a partial meniscectomy, just to trim out that inner third. And that is how it looks at the end of the procedure. Then you trim off that inner third meniscus, then that get a stability. So sometimes you get a patient of 38-year-old female patient, 6 months duration. This patient has got no locking instability, only pain. But you see the MRI, there is a complex tear of the meniscus. So this we plan for a meniscectomy. You can see this is a complex tear which was flipped between the femoral condyle and the tibial side. That is the flap which gives the problem whenever the foot load and twist. So once you see this kind of fragment, this patient definitely required a pike resting. You can see that after a pike resting, you can see some opening over there. Then you do the partial meniscectomy. So in this case, you see that flipped fragment was done the partial meniscectomy. Once you done that, you see there is a big horizontal tear of the meniscus, which you may not expect many times. So this case, we planned for a meniscectomy. But when you see in young patients with big horizontal tear with unstable meniscus, we tend to do a excision of the one flap before. But in young patients with the good healthy meniscus, but sometimes you can do a repair. You can do the same instrument which I used for that radial tear can be used for these horizontal tears. You add a multiple stitches for the both superior and inferior flaps like this, and the end of the 4 or 5 stitches will add a stability. But also you may add on an inside all inside technique stitches that gives the stability of the posterior horn of the meniscus to your capsular. Because this kind of horizontal tear with the complex tear will have an instability. But at the end of the procedure, you can see this is how you get. So instead of excising the meniscus, you can have a complete stable meniscus, you do the repair of the horizontal meniscus. It doesn't mean that you should do, it's a controversy, you don't repair all the degenerative tear, but when you have a young patients with the good cartilage, with the cyst with the horizontal tear, can be repaired too. Okay, to conclude, the meniscal repairs is a deep learning curve. Of course, it's an expensive, a patient has to be counseled for these kind of procedures, but saving the meniscus and knee is also very important at the same time. So you have to balance between these two. Thank you very much.
Thank you, Dr. Sundar.
So with the help of the chair, sir, I invite all of you for the IAS Con 2022 to the Coimbatore, September 15 to 17. The early bird registration is extended up to 30th of the April. This hotel is a Lee Median. We have a lot of international faculties, more than 25 live surgeries, and we have a master class program for especially for the beginners separately apart from the main conference. And abstracts are so open. So the May 30th, 31st is the last date for submit your paper for abstract. We have 4 awards for that. We have a 2 days cadaveric lab in Singapore. And also we have a best paper, we can go for a 1 week Europe fellowship. Thank you very much.
Thank you for your invitation, Sundar.
If anybody wants to do a registration, you can meet me. We have the forms also. Offline registration. Thank you, sir.
Thank you again for the invitation and on your nice talk on the how to do the various modalities of meniscal repair. And I want to insist the point that after an MRI, you see asymptomatic tear, you should not jump and do surgery, and better you be careful about it. So youngsters should not be the patients are more aware, they are more about the thing. So asymptomatic tear, be careful and go ahead with the surgery, only if it is symptomatic. Next, I call upon Dr. Palnivel Rajan on the management of the root tears and ramp tears. How we do? Over to Palnivel Rajan. He's an orthoscopic surgeon from Madurai, alumni of Madurai Medical College.
Good morning, friends, respected chairpersons, and all the faculties. First of all, my compliment to Preeti Hospitals and the team for organizing this wonderful conference, and the Indian Orthoscopic Society for allotting this program to Madurai. My talk will be on meniscal root tear and ramp lesions. These are the two interesting meniscal tears that has evolved in the last decade. Before that, we were not very much aware of the root tears and the ramp tears and their implications on the degeneration of the knee as well as the stability of the knee. So the root tears, each meniscus is rooted down into the tibial plateau at the two ends. So any radial tear that happens within 1 centimeter of the meniscal insertion or avulsions at the insertion site are called meniscal root tears, and failure of the meniscus to convert the axial loads into transverse hoop stresses is the main defect. So that causes degeneration as well as instability. So as been already described by previous speakers about the attachment of the meniscus, both anterior and posterior roots. So extrusion of the medial meniscus has been observed in both partial and total meniscal root tears. And with the extrusion being more than 3 millimeter is being associated with high cartilage degeneration and osteophyte formation. So a lot of importance is given now for the root tears. So there's also change in the loading pattern, and so early degeneration has been seen as similar to that one you see in a total meniscectomy. So you need to give some importance to the meniscal root tears. There are two types, like acute tears, which occurs in a trauma, usually young athletes, and more often a lateral meniscus is more involved. And in chronic tears, which is mostly associated with the degenerative changes in the knee, and that needs to be taken into account. So the most important thing is the imaging technique. You have to see the presence of any degeneration, whether it is a pan arthritis or the arthritis involves only the medial condyle or medial surface, medial joint, as well as the malalignment is very important because root tears are very often seen in patients with varus deformities, and so that needs to be considered. And any bony avulsions should also be noted. The gold standard is MRI, so it's very sensitive as well as it is very specific. You can see, I'll just show you the different views, how you diagnose this root tear. So you see a linear high intensity signal intensity perpendicular to the meniscus at the meniscal root lesion. And this is very important. In the axial, so in the axial C, you can see the linear high intensity perpendicular. It's perpendicular to the meniscus, so that is very important. As well as you see a vertical linear defect on the meniscal root. It's called the truncation sign, which is associated with meniscal extrusion. And also in the sagittal plane, you see a ghost sign where there is an absence of the meniscus, and that also needs to be taken into account when you study the MRI. So usually it is a benign twisting motion, more often or a subtle pop and joint effusions in case of acute injuries. Whereas in case of the degenerative tear, which is very common with medial meniscus root, the patient often complains of just getting down the stairs or getting down from a vehicle, gets a pop sound, and then the pain starts, aggravating over a period of time. So that is the common. I think this has already been discussed. So it's the type of root tears, which type 1 is a partial root tear, and the type 2 is complete root tear. Type 3 is along with the bucket handle tear, you have a root tear, and type 4 is an oblique. And the other issues that you commonly see in the medial root tear is the extrusion of the meniscus, which may precede the degeneration of the joint rather than the result of that. And the spontaneous osteonecrosis is the result of both OA as well as the root tear, which often gives the symptoms like severe pain. So the treatment modalities are just to restore the joint contact pressures, joint kinematics, and you delay the development of OA. So non-operative and operative treatment both can be tried in case where patients or the old, there is a lot of varus or varus alignment deformities, or there is a pan arthritis. You can try a non-operative treatment for a short duration of time before going for a replacement and other things. But whereas in patients who have lesser arthritic changes, who has less alignment problems, and younger age group, it's always good that you attempt to repair the root. Again, lateral meniscus root tear, sometimes you don't need to do surgeries in acute cases if it is very stable or if the meniscofemoral ligament is intact. And again, severe OA changes, you don't need to do non-operative treatment. Lot of surgical options available. You can do a transosseous pull-out sutures, or you can use a suture anchor or a side-to-side tear. So this is a 50-year-old female patient who had a sudden pop sound when getting down the stairs, and then after a brief period of pain, the pain got aggravated, and she is not able to put her leg on the ground. And then MRI was taken. MRI showed there is a tear in the posterior root of the medial meniscus. The joint surface are reasonable, and the alignment is not bad. So in these cases, you can attempt root repair. I'll just show you the video of how we do the meniscal repair. So once you identify the unstable root attachment of the medial meniscus posterior horn, the first thing you need to do is you just debride the edges because it's more degenerative. You have to create some biological induction, And then once you debride, sometimes you may need to mobilize the meniscus a little bit. Otherwise, you can't pull it too tight. It may fail. So once you are sure that you can bring the meniscus and get it attached to the posterior root, there are so many different ways of doing. You can either drill a tunnel and then you can take bite, or you can take bites and then you can drill a tunnel and bring it down. So I always take a couple of sutures, as Dr. Sundarajan told, using the specialized instruments. I take a cinch, one cinch and one simple suture. And you can mix and match a different kind of suturing in repairing the root. So you have to take a thick tissue because it's a little degenerated. You have to be sure that you take a good chunk of the posterior horn. And after one cinch, I take one simple stitch, and then I use a jig. There's a special jig available for creating a root tunnel. And using the jig, you can drill a hole near the attachment site to bring the meniscus back, and to prevent the extrusion. You have to choose a site where the meniscus is not too tight or not too loose to get extruded. So once you drill a tunnel, you have to be very careful that you don't pierce the posterior capsule. You have to give a protection. Once the K-wire is drilled or a drill bit is used, then you use I use a 4.5 reamer. The idea is to make a bigger hole so that it has a better bleeding and more biological healing potential. And once the tunnel is drilled, I take a lasso and bring both the sutures down. I think, next video. Yes. Yes. Okay. So both the sutures are brought down. Using a lasso, you just take both the sutures down. And once both the sutures are pulled, initially I used a simple stitch to use a sliding knot so that you get a very snugly fit. Nowadays, I just pull one suture and tighten with a simple knot, not to slide the suture because it may damage the meniscus. Once this is done, the meniscus is, I use 2 fiber wire. A lot of people use one. It's up to you to decide which one you want. So this is a post-op picture. You have a small button on the medial side, and that gives the attachment site for the meniscus. This is another case, like sometimes you may have some adhesions attached to the torn root in a chronic case with some degenerative changes. You have to identify the stability of that. And if you find that the root is torn, this is a chronic case where once the root is detached, it got adherent to the posterior capsule and it's too tight to bring it back. So we have to release a little bit. Once you release, again, the procedure is almost similar. You just try and find out where you can attach it in such a way that it functions physiologically. And then you again take the sutures. The most important thing is you have to take sutures so that it doesn't cut through the meniscal tissue. So once you take it in more, say inner part, there's every chance that the meniscal, it may cut through. So again, the similar procedure. For post-operatively, because I use 2 fiber wire, I mobilize the knee in the first week, but weight bearing, I wait for up to 6 weeks. At least 4 weeks for full non-weight bearing, and then partial weight bearing, and end of 6 weeks, we put them on full weight bearing and normal walking. Squatting as well as, so this is another different method of button fixation. Squatting we allow after 3 to 4 months. So meniscal root tests may be subtle and may be missed. So consequence of non-diagnosis are rapid onset degenerative disease. So we have to consider the chance of repairing. And when a benign twisting medial thing is there, small pop or crack, if you get history from the patient, then you have to suspect the root tear. Again, ramp lesion, again, it's a new concept in the last decade. It's always associated with an acute injury, very commonly seen in young patients. The posterior capsule and the meniscal attachment site is torn within 1 millimeter of the meniscus. And then we call it as a ramp lesion. So the hypothesis is that the contraction of semimembranosus, the capsular arm at its insertion along the posteromedial capsule, causes this sudden pressure, and this with the stress of the peripheral meniscus results in a meniscus capsular tear and instability. So always associated with 15 to 30% of ACL injury, and not every patient needs surgical intervention. If the tear is very small, like it's less than 1.5 or 15 mm, and then you can, if it is very stable, you can just debride and leave it. Otherwise, you have to repair. This is a classification like what the previous speakers have told, that it is the peripheral one is type 1, and one involving the superior surface is type 2. The one involves the inferior type 3. If it is a complete tear in the red zone within 1 millimeter of the meniscus, peripheral meniscus, then it's type 4. And then if it is a double tear, it's type 5. So it since meniscus, I think, supports the anti-translation, so we need to repair this. So small tears, you can just do a trephination, and you can do rasping, and the bigger tears you need to repair. Again, a lot of techniques are evolving in repairing. I'll just show you how I repair. So always you see the trans notch view, you can diagnose the presence of the tear. If you are not very sure that you can't see that, then you can use a posteromedial port, and then you can see the meniscal tear. Right? So you make a posteromedial portal, and then you view it through that. You can see here the tear. It's very difficult to find in little chronic cases, as the capsule is very lax. But if the meniscus is very lax and you couldn't find any meniscal tear, then you always suspect that it could be a ramp lesion. So for repairing, I always use posteromedial portals. I make 2 portals on the posteromedial side, one inferior posteromedial and one superior posteromedial portal. The inferior one I use for taking stitch, the superior one for suturing. So I pass a cannula on the superior posteromedial portal, and for the inferior posteromedial portal, I don't use a cannula, because if you use a cannula, it is very difficult to manipulate and take as a bite. Most often I use lasso. We have to prepare this more with the rasp and less with shaver, because shaver might take away the capsular tissue. So we have to be very careful when you are using shaver. So once this is done, you use a lasso, and then you take a thick bite through the capsule. And once you are sure that you can't take a single bite through both the tissues. So once you are sure that you are taken through the capsule, then take through the peripheral 1/3 of the meniscus. You should not go beyond that, not necessary. You can take 1 or 2 stitches. So just take a stitch and take it through the superior portal where you have a cannula, and then you can use different type of knotting, like either you can use a sliding knot or a simple knot, and then you can repair. If you find it very big, then you can use 2 switches for that. So once you find out the ramp lesion and then you repair that, you'll have a good clinical outcome, low reoperation rate or low re-injury rate of the meniscus, and the patient returns to sports in majority of the time. Thank you.
Thank you, Palanivel, for your exhaustive talk on management of root tears and ramp tears. Now I call upon Dr. Mukesh Ladda from Nagpur to give a talk on arthroscopic ACL reconstruction, step by step by hamstring tendon graft.
Good morning, everyone. I would like to thank Preeti Hospital and IAS for giving me this opportunity, and my good friend, Dr. Parlad, for asking me to come down here to the city of temple. Visited first time Madurai and saw the magnificent Meenakshi temple yesterday. Thanks a lot. So this is more of a practical talk. So please pardon me. There won't be any theoretical aspect in my talk, because its talk is stepwise reconstruction using hamstring tendon autograft. So I come from Nagpur, Maharashtra. So you can do ACL reconstruction in leg dangling position or in TKR position. I prefer to do it in leg dangling position. Do your surface marking, patella, tibial tuberosity, joint line, and then mark oblique incision just about a centimeter below and medial to the tibial tuberosity to harvest your CME graft. So always do evaluation under anesthesia to assess the pivot grade, so that you can know whether you are dealing only with ACL or some root tears or ramp lesions, or you have to do some anterolateral reconstruction. Then you incise, palpate first, and the thing which is palpable is the gracialis. Take a longitudinal incision in the sartorial fascia, hook your CME out from below, and try to take about a centimeter or so of periosteum from the bone, so that you can increase the length of the graft as well as it helps in healing. The important step is to cut the vanculas here. It's the attachment of the graft to the gastrocnemius. While doing so, see that the tip of the scissor is below and not towards the tendon, otherwise invariably you will cut the tendon. And try to hook the second vancula out. Don't pull the graft. If you keep pulling the graft and the vancula is attached, it reduces the thickness of the graft, and completely clear it with your finger and see you get that springiness. Hold it firmly and then use your tendon stripper to remove the graft. Clear all the muscle tissue. A small amount of muscle tissue may cause a vascular necrosis of it and tunnel dilatation. Then prepare your graft with a Chinese strap method, with holding it on a graft board or with it, and then measure the diameter. The diameter should be minimum 8 mm. If you feel the fold is not giving you 8 mm, add gracialis to it. Then mount it on the graft board, tension the graft, and cover it with vancomycin soak gauze piece. So tip to graft harvest, you can have oblique incision because it prevents injury to the nerve, superficial nerve, more cosmetic. The palpable one is a gracialis, so CME lies below that. Incise with periosteum, identify the vanculas. Most important to differentiate it from gracialis and the CME. Cut the vanculas to prevent premature amputation of the graft while harvesting. Hold the graft firmly with ethibond when you are harvesting with a closed or open tendon stripper, because otherwise if it slips, it will suddenly pull inside and it will be difficult for you to get the graft outside. Pull and push the graft gently with the knee in 90° of flexion to harvest the graft. So once you prepare your graft, you can use either accessory anteromedial portal or a single anteromedial portal which is lower enough. So you make a horizontal medial portal because it's quite low. If you make a vertical, there are high chance you may do a radial meniscal tear. So if you make a horizontal, it will be an intra-substance injury. So once you do your portal making, you see that's the Blumenstedt's line, or you may say the residence ridge, and this is the bifurcate ridge. So your tunnel should be posterior to the bifurcate ridge and below the residence ridge. So that's the area where your ACL femoral tunnel should come. I always use a femoral offset guide. If it's 9 mm, I use 6 mm offset guide, which hooks on the posterior cortex. and then you drill with your bead pin from medial to the anterolateral cortex. This is the offset guide I always use, and then you drill with 4.5 mm drill bit to whole tunnel till the lateral cortex. And so while you are drilling, when you reach the lateral cortex, you can know the total length of the tunnel so that you can adjust your graft accordingly. And then you make a socket with the 8 or 9 mm drill bit, depending on the graft of the size you have. Minimum 15 mm graft should be there in the femoral tunnel. 15 to 20 mm you should drill. Once you finish the drilling with the graft, clear the mouth here on the femoral tunnel, because once you pass the graft, this soft tissue may tend to go in the graft and will hamper the healing at the mouth, because the healing takes place at the aperture of the tunnel, not in the tunnel. So when you pull the graft, this soft tissue tends to invert in the tunnel. So clear the mouth. And as I told you, the tunnel should be below the residence ridge and behind the, below the residence ridge and behind the bifurcate ridge. So this is the single circular tunnel ACL reconstruction femoral tunnel we do. So the tips here, you can make an accessory anteromedial portal or low anteromedial portal just above the medial meniscus and see that that portal is horizontal. Use offset guide. If you are comfortable without it, you can do that way also. I use offset guide. The knee flexion should be around 110 degree. Guide wire followed by reamer to break the lateral cortex. If you are using an adjustable loop, the socket length can be 15 to 20 mm. But if you are using a fixed loop, you need to make a socket 5 to 10 mm more for the turning radius of the implant. Visualize the portal through anteromedial portal. Visualize the tunnel through anteromedial portal always for self-learning to know whether you are little high or little low in the center. And as I told you, it should be below the residence ridge and behind the bifurcate ridge. For tibia, you can use either a tip aimer jig or an elbow aimer jig. I prefer to use tip aimer. If you are using a tip aimer jig, see that you are in the center of the footprint. If you are using an elbow aimer, see that you are just below the posterior border of anterior horn of lateral meniscus. Use that as a landmark. So angle of the jig should be around 45 to 50, and the bullet, mallet it on the anteromedial tibia so that it should not slip while you are drilling the guide wire. Otherwise, the guide wire may not come in center exactly. I prefer tip aimer so that my guide wire comes exactly in the center of the footprint. Hold it with the artery forceps and drill it with the respective diameter, tunnel diameter which you have. Clear bit amount of tissue anterior to the tunnel of the tibia to avoid cyclops formation and also to bring out all the bone debris. So the angle should be around 45 to 50 degree. Mallet the bullet on anteromedial tibia to avoid the slippage of the guide wire. The entry should be between patella tendon and anterior part of the MCL. Be careful while seeing so that you don't damage the anterior half of MCL. Tip aimer, because exactly in the center, if you are using elbow, just posterior. Identify the anterior horn of lateral meniscus as a landmark to make your tibial tunnel. Hold the guide wire. Try to preserve the remnant of ACL for proprioception and better healing. Once you have finished that, if you are using an adjustable loop, you can do a marking of the whole tunnel on the loop. As here in this case, it was around 30 mm whole tunnel. And then you mark here because this is an adjustable loop. And then you mark the area of the graft you want to put in the femoral tunnel, usually 15 mm. But if you are using an adjustable loop, see that you drill up to 17 mm and keep 15 mm marking, because after fixation, you need a millimeter or so to finally tighten the graft in the femoral tunnel. Now the time is to pass the graft from the tibia to the femur. You can ideally see the button flipping from the tunnel view from anteromedial portal and slowly ask your assistant to pull the button out from the femoral socket. Slow and be very gentle, and you can actually see how the button gets flipped on the lateral cortex over there. And once you flip the button on the lateral cortex, pull it below from the tibia so that if any slackness is there, and that's your marking where exactly the tunnel ends, and then pull the graft. If you are using an adjustable loop, I'll just do adjustable loop. Different companies have different ways to pull it. So follow all the instructions. Mark the whole tunnel length on the loop and socket length on the graft. see the button flipping under vision. If it's a fixed loop, always do cycling after you toggle the button on the lateral cortex. There are chances that you may toggle the button on the IT band. So if you see the puckering of the skin on the lateral cortex while doing flexion extension, see that you are not on the cortex, you are on the IT band. Or if you suddenly feel that the length of the graft has gone too much inside and you are not able to see on the tibia, feel that you are not on the bone. So then you have to take a small incision laterally and try to pull that button on the lateral cortex. No graft tunnel mismatch should be there. Be careful, because if your graft is smaller than the tunnel, then there are high chance of tunnel dilatation and graft failure. So while fixing the tibia on the finally, now you have to fix the tibia in 20 to 30 degrees of flexion. You have to firmly pull the graft, your assistant giving a posterior drawer, and you are putting a screw or suture disc, whatever you prefer. I usually prefer to put a bio screw if I have a graft at the mouth of the tunnel. But if the graft is about, say, more than 5 to 7 millimeter in the tunnel, I'll prefer to use a suture disc. Posterior drawer is a must when you fix. Hold firmly and pull the graft. And the size of the screw is usually one size more for bio and one size less if it's a metal screw. And then finally you check after you fix the tension on the graft, you see full extension of the graft so that there should be no impingement. And if there any tissue or the remnant is there on the anterior aspect of the tibial tunnel, and you feel that it will form a cyclops lesion, you can remove that small amount of remnant ACL. And if you have good amount of bundle preserving, you can even preserve the bundle and do ACL reconstruction. That's the remnant preserving. It's hugging the graft, which helps in proprioception and faster healing. We all know we are doing this technique since ages, and we have excellent results with this technique of single bundle, circular tunnel, anatomical ACL reconstruction. But we all know the amount of footprint coverage with single bundle is around 57 to 58%. And we are either creating AM bundle or AL bundle, or we are in between them. So with the same concept, Freddy Fook came out with double bundle ACL reconstruction so that we can form both the bundles and we can have more footprint coverage. But we all know the fate of double bundle, double trouble, technically very difficult, and we have a lot of trouble. So we have all moved from double bundle again to anatomical single bundle. So can we do something to increase the footprint coverage with the same hamstring graft using a single tunnel? With keeping that in my mind, I have prepared a new technique of ACL reconstruction with a rectangular tunnel using the same CME hamstring graft. So we have prepared a special tunnel dilators which are rectangular rounded. And after you prepare your circular tunnel through the same portal, we are dilating the circular tunnel and converting it into a somewhat rectangular oval femoral tunnel. It's a marked with 5 mm increment so that you can gently tap it and convert the circular femoral tunnel into a rectangular or oval femoral tunnel. So this is the original ACL footprint. This is what we create with a circular tunnel, and we get good result. But with our new technique, we can increase the footprint area and we can have a bigger femoral tunnel compared to a simple circular tunnel. This I have done on a cadaver also, and you can see this is what we reconstruct the single bundle anatomical ACL reconstruction. And the same thing, if we are using a tunnel dilator, special tunnel dilators, you can convert that circular tunnel into a rectangular tunnel without blowing out the posterior cortex, but increasing the surface area, both superior inferiorly and anterior posteriorly. Similarly, on the tibia, we do routinely this circular tunnel and it's perfectly well, but the amount of ACL still is not covered. So we are using the same rectangular tunnel dilator and converting this circular tibial tunnel into a somewhat rectangular tibial tunnel. So this is what the original tibial footprint is. This is what we recreate with our single tunnel. And this is what the new tunnel with special tunnel dilator, increasing the surface area. Even on cadaver, if you see, even the footprint, if you see mentioned in the literature, is not circular. It's somewhat rectangular in shape. And this is what we are recreating with this special tunnel. And we use the same graft, but the philosophy is little different here. If you have a 9 mm circular hemi-string graft, you have to drill first with 8 mm diameter and then sequentially dilate that 8 mm into 8 by 10. Means sequentially the medial lateral will remain the 8, but then you convert that 8 diameter into 8 by 10 horizontal. And since you have a 9 mm diameter graft, which is a soft tissue graft, it will squeeze from one side and it will expand from other side. So it will cover whole of the tunnel with the same CME graft. And after you view from the posterior medial portal and you see it will mimic more of a kind of double bundle, like when you are extending, the posterior lateral bundle is getting lax and the anterior medial is getting taut. And when you flex, you can actually see that the posterior lateral is getting taut and anterior medial is getting slack. It's a sort of double bundle. I may not say exactly the double bundle, but increasing the footprint coverage will give you more of a double bundle. Same on the cadaver. The anterior half of the graft will go medially, will give you anterior medial, and the posterior half of the graft will go more laterally. So you will mimic more of a double bundle with a single tunnel. And as you extend the knee, you can see that the AM bundle is tight in flexion, and as you extend, it becomes lax. So mimicking more of double bundle, but with single tunnel. And a simple mathematical calculation says that we can increase the surface area by 25% of the existing circular tunnel. And this is an MRI of the same patient done 8 months back. And you can see how beautifully the graft has grown with no tunnel dilatation, as the graft has completely matured in the sagittal cut. Even if you see the axial cut, you'll see the rectangular tunnel, which is very well in the center of the footprint and no tunnel dilatation. Even on the coronal cuts, the post-op MRI of the same patient shows that the graft is exactly between the two tibial spine, medially and lateral. So this is the small variation in routine ACL reconstruction developed by me and my team. Thanks a lot.
Hello. Nice. Dr. Mukesh,
Thanks, sir.
coming all the way from Nagpur and having a good darshan of Madurai Meenakshi. Madurai is famous for all hospitality, and especially Preeti Hospital. We give good hospitality. Hope you will enjoy it. And nice of you talking about the ACL reconstruction and your recent paper on how to convert a round tunnel into a rectangular one, and how the single bundle causes both double bundle like effect. Thanks. I have more questions in the session from the audience, I think, on your new technique.
Now I call upon Dr. K.P. Saravanakumar, a local boy, to give his talk on arthroscopic ACL reconstruction by bone patellar tendon bone graft.
Good morning, everybody. First of all, I would like to thank Professor Dr. R. Shivakumar sir, my teacher, and Dr. Prahalat, my friend, for giving this valuable opportunity. Thank you, sir. My topic is arthroscopic ACL reconstruction using PTB, step-by-step approach. Among all graft, we are having so many graft. Commonly, we are using hamstring and PTB, but using hamstring is very high as compared to the PTB. So why PTB is can be used? PTB is originally described as a gold standard graft in our textbook of Campbell. Very strong graft, good fixation strength is offered by PTB. This will provide a yearly rehabilitation. Good bone-to-bone strength healing is there. Predicted outcome is there. This is less complicated technique. Residual laxity is less as compared to the hamstring tendon. Then cheap and best. We can finish the surgery with a couple of titanium screws or even SS screws for low budget cases. So generally it is reserved for high demand individuals like athletes, pivoting sportsmen, military and policemen, manual workers, and obese patients. As like any other ACL reconstruction, diagnostic arthroscopy, we are doing articular debridement, notchplasty, preparation of the tibial and femoral attachment. Then we can do graft harvesting and in a 2 incision or 1 incision technique. 2 incision, one for graft harvesting and one for tibial tunnel creation. We can do it with one small J-shaped incision, avoiding incision over the tibial tuberosity and the infrapatellar branch of the saphenous nerve. Small J-shaped incision. Through this incision, we can harvest the graft as well as we can create the tibial tunnel also. Then after the exposure of the graft site, we have to demarcate the proposed site of graft harvesting. Usually the patellar plug, bone plug should be 2 to 3 centimeter in length. Diameter, usually I take 10 mm diameter. And also the patellar tendon 10 mm diameter and tibial plug also 10 mm diameter and 2 to 3 centimeter in length. Then after outlining, we have to take the harvest graft with the thin blade, oscillating saw blade. The direction should be 45 degree to avoid patellar posterior cortical rupture, cortical rupture of the patellar bone. The posterior cortex should not be disturbed by making the angulation 45 degree either side. So the triangle size graft will be taken. The depth of the graft should be 5 to 8 millimeter to avoid posterior cortical break. Then is the removal of the patellar bone plug, patellar tendon, and tibial bone plug. Then before preparation, when we are harvesting, please don't forget to harvest along with the tibial tongue. The tibial tongue is nothing but this projection from the upper part of the tibial bone plug. We have to take along with this tibial tongue. This will be useful for to avoid graft tunnel mismatch. When we are having very short tunnel, tibial tunnel, and the graft is hanging outside, that is tibial bone plug is hanging outside. It is fine. We are finding it's difficult to fix into the tunnel. So in this case, the tibial tongue will be helpful, and this will be engaging in the tibial tunnel. So graft preparation after harvesting, we have to trim the graft according to our need. That is 10 mm diameter and 2 to 3 cm length, as previously said. This bone fragments can be used for grafting the patellar defect or tibial defect, so that we can avoid the anti-knee pain also. Then this is a sizing cage, 10 mm diameter. Both bone plugs are being sized. Then after that, we have to create holes in the patellar bone plug and tibial bone plug. 2 holes in the patellar bone plug with the help of the K-wire or a thin drill bit to prepare with the number 5 ethi bond. See, this is patellar bone plug. We are tying the patellar bone plug with the number 5 ethi bond in 2 holes, and this ethi bond in turn attached with the bead pin. And on tibial bone plug, the number 5 ethi bond is attached. Then creating tibial tunnels, for comparing with the semi-T, we have to create tunnel length, adequate tunnel length, because short tunnel is not favorable for PTB, because the length of the tendon, length of the graft is fixed in PTB as compared to the semi-T, in which we can adjust the length of the graft. But in case of PTB, we cannot adjust the length in great extent. To some extent, we can adjust, so that we have to create the tunnels with good length. So the angle we have to fix in the tibial tunnel is 45 to 50 degree generally, and we can discuss in the next slide. The placement, when we are fixing the tibial jig, the placement of the jig is outside the knee joint or the anterior surface of the tibia is 4 centimeter below the articular margin and 3 centimeter medial to the tibial tuberosity. And the angle between the jig and antecortex is 30 degree. Inside, as Mukesh sir said, this is the side, the positioning is extension of the inner border of the lateral meniscus 7 mm anterior to the PCL. So comparing the tibial tunnel angle and length, when we are choosing 45 degree, we will get short tunnel but superficial tunnel. When we are putting 60 degree, very long tunnel but vertical and deep tunnel. So we usually choose 50 to 55 degree to fix the angle in the tibial jig. Then creating tibial tunnel. So through the jig, guide wire is passed, and this is the inside guide wire is touching the jig. Over the guide wire, reaming is done. Reaming is done as we are creating the craft for 10 mm wide width. So 7, 8, 9, 10 reamers are used, up to 10 reamers. Over the guide wire, this is reaming is done for to create the tibial tunnel. Then creation of the femoral tunnel. Regarding CME, we can create very horizontal tunnel, as Mukesh sir demonstrated, very horizontal up to 3 o'clock position or 9 o'clock position. We can create the very horizontal tunnel. But when we are creating the horizontal tunnel to make the anatomical tunnel, the tunnel length will be very much limited. That is a 20, 25, 30 mm. That's all. But when we are using PTB, the tunnel length at least should be 35 to 40 to accommodate the graft well inside the femoral tunnel. So 3 methods are used. One is transtibial technique, transportal technique, and a modified transtibial technique for creation of the femoral tunnel. Transtibial technique, we are aware the tunnel is created, femoral tunnel is created through the tibial tunnel by means of a femoral aiming device. The advantage is technically easy. We will get more tunnel length, but the disadvantages are more vertical tunnel and less anatomical. When we are using transportal technique, which is commonly used for CME, the graft femoral tunnel is used created through the anteromedial portal, which is more horizontal tunnel, more anatomical tunnel, but disadvantage is technically demanding when we are using freehand and less tunnel length. So combining these advantages of both techniques, we are using modified transtibial technique. What is that? Modification at the tibial side is the entry point is shifted 1 centimeter superior or 1 centimeter medial to the conventional entry point of tibial tunnel. This is nothing but the point of intersection between the anterior margin of the MCL and upper margin of the pes anserinatus, exactly this point. When we are using this site, we will get the good length tibial tunnel with a good angle. Knee is placed in the varus and indel rotation position to get this good femoral tunnel. Varus and indel rotation as well as in flexed position. Then on the femoral side, the femoral aiming device is rotated a little bit horizontally to get 10 o'clock or 2 o'clock position. So the comparison of the guide wire holds. This is transtibial technique, which is more vertical, transporter technique more horizontal, and modified transtibial technique is in between. Then the femoral guide wire is passed through the femoral aiming device. Reaming is done. See, we can get up to 40 mm length of tunnel in femoral side. So after creating the femoral tunnel, roof is pierced by the 4 mm drill bit, and this is the final appearance of the femoral tunnel. Graft passage. So the prepared graft is passed through these tunnels. First, the big pin is passed through tibial tunnel and femoral tunnel and through the anterolateral aspect of the thigh is executed. This is followed by the patellar bone plug first, then followed by the tendon and tibial bone plug. So this is the importance of the tibial tongue. In which some portion of the graft is hanging outside. So the tibial tongue is very well engaging inside the tibial tunnel. So this is graft passing through the, that is patellar bone plug passing through the femoral tunnel. Through the anteromedial portal, the guide wire is inserted in the tunnel and bone plug, and over the guide wire, titanium screw is applied. This is 1825 mm titanium screw, and this is fixation of the tibial bone plug inside the tibial tunnel. This is the final appearance of the PTB as ACL. Very taut and regarding fixation, we have to prefer aperture level fixation, very important, because as sir said, the healing is occurring at the aperture level. So here the graft should be fixed at this point, and at the tibial side, entry level fixation is very ideal rather than the aperture level fixation. Because in this both fixation, we are getting good hold to the graft. PTB is previously thought to be very complicated procedure and known for its complication, but we can very well manage the complications. For example, graft side mobility, this is pain on kneeling, can be very well avoided by the oblique incision, avoiding the incision over the tibial tuberosity, very small incision, and bone grafting can be done for tibial and patellar bone defect. The numbness is because of injury to the infrapatellar branch of the saphenous nerve. So we can avoid nerve injury by avoiding incision over that. Anti-knee pain is very high in PTB, that is 20 to 40%, can be avoided by good rehabilitation and early rehabilitation and all. So graft abrasion, when we are abrasion the screw inside the femoral tunnel, it can abrade the graft and it may rupture the graft. So to avoid that, we have to flex the knee joint to 120 degree. While applying the screw, and we have to apply the proximal distal traction to make the graft taut and to avoid the graft abrasion. Very common complication is graft tunnel length mismatch, because the length of the graft is fixed. So we have to adjust to some extent. The reasons for graft tunnel mismatch are long graft because of tall patients, long patellar bone plug 4 centimeter and all, horizontal and short femoral tunnel by means of our transportal technique and all, short tibial tunnel with low angle jig, 45 degree, 40 degree, will get very low and superficial, short length tibial tunnel. So to avoid that graft tunnel mismatch, the solutions are, we have to create a long tibial tunnel with a high angle jig. So we are using 55 to 60 degree, 50 to 55 degree commonly. Long femoral tunnel can be created by either transtibial technique or modified transtibial technique. Then we have to make the patellar bone plug short, 2 to 3 centimeters is enough. Then tibial bone plug should be harvested with this tongue. This is the tibial tongue, harvested with the tongue. Unavoidably, sometimes if very long graft, we can push the patellar bone plug deep inside the femoral tunnel and can fix in the middle or upper part. This is actually this is wrong, but in sometimes unavoidably we can do it to make this. Then backup fixation. Backup fixation, sometimes if any problem is arising, the tibial bone plug is hanging outside, then we can use the anterior screw post. So to conclude, PTB is the technique is a gold standard, absence of graded laxity, early mobilization, surgeon friendly, solutions for complication available, less revision surgery as compared to the hamstring. This cheap and best. These are the advantages. So it may be the re-emerging trending. Thank you for this opportunity.
Thank you, Saravana Kumar. And I thank all the speakers of this session. Unfortunately, we'll have to have a discussion over this only after the live surgery. We'll have the live surgery now. I thank the organizers for giving us an opportunity to change this session. And
thank you, sir. Thank you very much, sir. I invite our professor, our IAS Secretary, Dr. Sundarajan, sir, to felicitate our chairpersons. Sir. Professor Dr. Chidambaram, sir. Professor Dr. Satyanarayan, sir.
Yes, sir. Yeah, over to live surgery. The case is
They will say in this study there was this.
short history. He said 28. Sir, ready, sir?
Hyperintensity in the fibers of the ACH and the hyperperformance and these two images are the coronal and T2 sections of the knee. This section we could see a medial meniscal in both these sections on this coronal images. In this sagittal cut, we would appreciate that here is on the posterior aspect, the horizontal kind of here can be applied.
We request Dr. K. Subramanian sir and Dr. Palnivel Rajan sir to moderate the live session on ACL reconstruction. The operating surgeon is Dr. Sachin Kapasi sir.
Good morning, Sachin. How are you?
All right, good morning, and I hope you can hear me properly.
Yeah, we are able to hear clearly.
After
Yeah.
the pandemic and all the Zoom sessions, this becomes mandatory now. Can you hear me? Can you see me? Isn't it? So, good morning to all of you, and thank you so much for all of you coming here to this session today. It's indeed a great honor and privilege to be alongside with respected Professor Sivakumar sir and respected Dr. Sundaran sir, our beloved Secretary of Indian Arthroscopy Society. And I'm looking forward to a very good interactive session with all of you. So I think you have the history of today's patient. So it's had a chronic ACL instability, and along with me, I'm assisted or rather directed by Dr. Prahlad. Prahlad has been with me since 2006, and I have learned a lot from him. He has always been a very meritorious and a very hard-working orthopedic surgeon, unlike me, and it's a real great honor to work with Prahlad. We also have here with us Dr. Dr. Sibu from some place 70 kilometers from here. I cannot pronounce the name. And we have Dr. Ranjit, who is from some place, I don't know from where. And the plan today is to do an ACL reconstruction. So it started a bit 5 minutes earlier than what we expected, and we just harvested the graph. Dr. Sudarajan, Dr. Sudarajan is going to show graph harvest technique. He has a very elegant way of demonstrating that, and I thought I would spend more time with the intra-articular procedure. So typically at this stage, camera one zoom in. Camera one. Typically at this stage, after the ACL graph has been harvested, I will camera two zoom in. Camera two, this camera, top camera, which is this camera. Okay, yeah. So this camera now, head camera, then that is camera, this camera. Inside only camera, as you don't have this inside camera. Okay, then camera one only to come in. I will repair the best fascia. I mean, I'm holding it with my tooth faucet, so you can't see too well right now because we don't have a top view. But I think it's really important that you should repair it. So now we want the graph harvest. Camera 3, come and show it from the top. Camera 2 standard. Camera 3, come and show it from the top. Alright, camera 3. Why you move? Can you stand here only? Why do you move? What's the move? Why camera 3? Stand here. Why do you shift it to this side? So we start with graph preparation. For graph preparation, the plan is to do either a 5 or a 6 and a hand should not come away. The plan is to do either a 5 or a 6 strand hamstrings. The first thing that you want to do is to make sure that you clean the graph properly. So here we are using a simple 12-inch ruler, and we're going to be cleaning up the graph. By cleaning up the graph, we want to remove all the muscle, which is that we want to make the graph look really nice, and that is how we do this. So a lot of preferences for doing graph harvest. You can do a graph harvest with open stripper. You can do it with a closed strippers. You can do it in a sort of a minimally invasive technique as well, where you are able to make an additional incision on the middle side of the thigh, and you can not open up the area anteriorly. What is important to understand is that no matter what you do, you should try to preserve the particular branch of the saphenous nerve, which may cause any form of which may cause hypoesthesia or anesthesia, and then may present, then will lead to a painful neuroma. Okay, so we have this graph. Unfortunately, this graph is not behave itself. Otherwise, we would have should probably teach on this rather than this here, so that it's in that direction. Okay, so see that right.
Sachin, so what is the length you want and what the diameter you are expecting?
Very nice, very good question. And that brings us to a very important topic as to what sort of diameter is expected from your graph. So you want to cover 80% of the footprint. What Ranjit did not mention is that preoperatively I measured the diameter, the footprint length of this patient's ACL tibial footprint on the MR scan. This tibial footprint is approximately 9 millimeters by 18 millimeters in length, and I want a graph which is going to be covering minimum of 80%. So 80% of 9 by 60 makes it around 8 to 8.5. So I want a graph which is going to be 8.5. That's the ideal width or the diameter that we want. The next question is what length do we want? So length is actually dependent upon the patient's height and the patient's weight, and what your origin length is what. And if you think carefully, let's say taller the patient, longer will be the hamstring graph. That's a no-brainer for sure. What is idea about 25 to 30 millimeters of infraarticular length? What about 20 millimeters, 50 to 20 millimeters, ideally 20 millimeters to go inside the femoral socket, and the socket should have at least about 25 to 30 millimeters if you're using a fixed screw on the femoral side or at the side. And if you are going to do trans-tibial screw fixation, and not use suspensive fixation on the tibial side. So that takes 30 plus 25 is 55, and another 20 is 75. So you want to have at least 75 to 80 millimeters of length of the graph, which is the ideal that you're looking for. Depending now upon the diameter, you will decide as to the diameter of the footprint. You will decide whether you want to perform a 5 or a 6 strand graph. I think if you ask me, there is not much goal of doing a 4 strand graph. Because a 4 strand graph generally reaches 8 millimeters, and a lot of papers that show that if your graph diameter is less than 7.5 millimeters, then the risk, I mean, we're talking about a hamstring graph, then the risk of failure of your ACL is as high as 25 to 30%. So this very important data, which has got very good evidence now, you would definitely have a graft which is no less than 5 millimeters diameter, that is absolutely critical in clinical practice. I would appreciate your comments as to what is your sort of standardization for graft harvest. So can you have a comment from both of you, please? Yes, Kate.
So say that again. Oh.
So I said this is my philosophy or ideology as to what should be the ideal graft diameter. Have any difference of opinion on?
No, I standardly use almost 9 mm diameter most of the time. Okay, 8 mm if I get it, I try to make it 5 stand or 6 stand at least to make it 9 mm. That is yeah. Yes, correct. 8 below 8 is usually not acceptable. Even in a thinner small individual also we try to make it 8 at least. Yeah.
Yes. So in your practice, what percentage of your grafts are full strand? What percentage of your grafts are 5 and what percentage of your grafts full?
No, in 70% of the patients, we were able to get a 6 standard graft of 7.5 to 8 centimeter length. And maybe in very few, like 10% of the patients, we couldn't make it beyond 5 strands, or we couldn't make 5 strands. In those patients, my preference would be to either go in for the opposite side, CME.
Okay, so you don't routinely harvest the gracilis, is it?
Yeah, of course we do. It's a 4 tendon quadrupled CME and doubled gracilis. 6 tendon.
Okay. Yeah, Prahlad, please soak that graft in the. Again, the next question is that if you see camera 3, if you see Prahlad has soaked the graft in vancomycin solution. So how many of you use vancomycin pre-soak for your grafts?
I think the couple of hands are being lifted up.
Okay, so I think I'm 100% vancomycin graft soaker, and you need to take 100 mils of vancomycin, 100 mils of normal saline, and you need to put about 500 to 750 milligrams of vanco. And the key to this is that if you, this is not opening, right, Prahlad? Yeah, now tighten it. Yeah. And then if you take a simple gauze piece, then that gauze piece will soak in about 6 ml of solution. So you have a 0.6%. You have a 0.6% solution of vancomycin, and that helps bring down the risk of infection. So I think with this, I've been able to bring down the risk of graft-related infections to almost 0% over the last, I don't know, maybe 6, 7, 8 years now. And we have multiple papers and meta-analysis on the same, which will corroborate the same evidence. So I think this vancomycin pre-soak has really helped improve our outcomes and our results. Again, the next question is that what do you suture your graft with? Normally you can use number 2 polyester.
About to ask, you are telling already. what material to stitch for whip stitch?
So
are you using ultra braid now, is it?
Yes, I'm using ultra braid because Prahlad wants me to use ultra braid.
What is the rationale behind that thought? The rationale is that's the rationale behind.
You will need to ask Prahlad after the meeting, very privately and secretly. Otherwise, number 2 polyester is what I use. Never use number 5. I've seen a lot of people use number 5. At least I will not recommend use number 5. That is one, because it forms a very bulky type of construct, and unnecessarily you have to drill very large tunnels to accommodate that number 5. That is one. Second important aspect is that don't go too overboard with your suturing, because if you keep on suturing over and over again, and if you have very long stitches on both ends of the graft, you want to avoid the presence of any polyester material inside your ACL tunnel, inside intra-articularly. So if you have something like polyester ethibond which is coming inside the ACL, then in that particular aspect, you don't really want that to happen, because the presence of any such material inside will always cause problems. Again, there's no use of a very thin tendon towards the end. So we're going to sacrifice that. We don't want such thin tendons towards the end. And that is the other thing that you will do. So I'm sorry if I'm being slow. This is a part of the surgery which I don't think I have done for several years now. So, which is why I think I'm not looking as elegant as what all of you expect. So please pardon me for that.
Kindly explain us about what you're doing now, because you're stitching the middle of the tendon, isn't
No,
it?
it's going to
See,
cut-
what
cut
has
the-
happened is that the end
Yeah.
of the tendon is so thin that there's no sense keeping that. It's not going to serve any purpose. And your sutures are also not going to hold. So
Augmentation.
no, I would have ideally liked to just cut off that remainder part of the gracilis, which I will just show in a moment, because the end of the tendon is extremely thin and we don't want to use that at all. So this is no augmentation. This is just some, this is all very, Prahlad, your hand is coming. This is all very thin tendon, which is of no use to us. So that needs to go. Okay. So this is what we have. This is our gracilis now. Again, my gracilis is measuring about 21. So I can do a 3-strand with my gracilis. And now we'll move on to using a fixed 20 mm endobutton loop. So somebody please get a fixed loop 20 mm endobutton.
Sachin.
Yes,
Sachin,
sir. Yes,
Sachin,
sir.
Sundar here.
Yes, sir.
So that means you are using 5 strands. That means you are using a triple semity and a double gracilis.
I will do a 6-strand graft.
Okay.
Okay, I'll do a 6-strand graft where I'll use a tripled semity and a tripled gracilis.
Okay.
I'm waiting for a 20 mm into. I open the 20. Come on, quick. People are waiting for us.
Only that is possible if you have enough length, isn't it?
I'm sorry.
If we have enough length in gracilis, we can use 6-strand or 3-strand. on
Enough
gracilis.
length gracilis, we can do 6-strand. You're right. Correct, correct. So we have now a 20 mm fixed endobutton loop. I'm not so much a fan of using adjustable loops. Adjustable loops are really good. I mean, there's really not much of difference between an adjustable and a fixed loop. So we'll show it on a fixed loop today. Prahlad, come to my left. And this is your fixed loop endobutton. Prahlad is going to hold it like this. I'm going to first take my gracilis graft. The portion of the gracilis which is thinner is the one that I am going to stitch to the end of my endobutton. So this is the end of my endobutton. My friend, you have to hold the graft in your hand. Huh? Put up a good show. Good boy. Keep tension and keep holding it. Okay. So we're going to be stitching one end of the graft in this particular manner here. Okay, so this is how I normally prepare. Prahlad, you should not do this, beta. Wait. Pay attention, Ray. Why are you sleeping? Oh, 1 second. Sorry. Yeah, why are you sleeping, Ray? So in the enthusiasm, he has pulled one end of the graft, which is why the second knot sort of slipped out. Sorry to put up such a shabby show, but these are common problems. Okay. Right, situation salvaged. Ranjit, why are you sleeping? Huh? Don't sleep. You also had alcohol last night? Oh, no? Don't have alcohol. Okay, so 2 knots, then take it through the loop again. After you've taken it through the loop again, then take a stitch through the tendon for extra anchorage in this particular fashion. And then another 3 knots. Prahlad, ask him to hold properly. Huh? And once you've done this, before you cut it, you pull and see that it is not coming out, because the last thing you want is that the graft just knife, the graft just knife 15 blade. Prahlad, don't shift. That the graft just pulls out and then you start landing in problems. Okay, so this is finishing with this. Again, now I'm going to come to the end. Prahlad, hold it here. We're going to come to the end. Knife, please. Give me the marking pen. Okay. And hold it here. Just to understand that this is the gracilis, we'll just make a mark with a blue pen. The next thing that you'd want to do is to take the two tails. Give me the two tails, Ranjit. Take the two tails, feed them in, take them out in this fashion. Get the graft through the loop like this, and then open up the two tails and bring it down in this fashion. So this makes your first 3 strand. And so that it does not shift out of place, I'm just going to tie a couple of knots on this so that it stays properly. Ranjit, hold this, be a good boy. Very good. Next, we'll take the other tendon and we'll again take the thinner side or the thinner loop of the same, repeat the same process. Ranjit is going to be more attentive this time and he's going to behave like a good boy. Again, hold it there. Yeah, can someone just take out the slack and give it to me? Arey Ranjit, what are you doing? Hold it there, good boy. Come, bring it closer, my friend. Bring it closer, my friend. Bring it closer and don't move. Okay, now we need 30 monocryl. 30 monocryl. Again, 3 knots there. Pass it through the tendon for a loop and then tie it down so that it stays in place and have 3 more knots again. So Ranjit, I want you to pull the other graph that you have. Pull this and show. Pull. Good boy. So it's not coming out, no, Ranjit? You're happy? Yes. Very good. Ranjit is happy. I am happy. And now we'll cut this out. Discard that. Show me this. Again, we repeat the same step in which we will feed the graft. Ranjit, please feed. Ranjit is a very bright boy and he wants to take over the practice of Prahlad, is what he was telling me just now, and banish Prahlad from this place. Prahlad, correct? Okay, so now we have our graft ready and now comes the time to size it. So Ranjit, pick up the sizer. The sizer number should be seen like this. You have to show it like this. So we're going to look at the tibial end. The tibial end is going to be a 9 or a 9.5 probably. The 9.5 or the 9 is going to be the tibial end. So we'll look at that. And now I'll look at the femoral end. The femoral end, 1 second, is again a 9.5. So the femoral end is a 9.5 to a 10. The tibial side is also a 9.5 to a 10. So I think a 9.5 graft is a good idea to have. And now this graft is going to sit in the endobutton cradle in this particular fashion. Take your hands behind. And we are now going to tension. We are now going to tension this. Why is this ulta, re?
Sachin, do you put monocryl also on top of this?
I'm sorry, 1 second. I can't hear you.
Do you put monocryl stitches on top of this?
Yes, I'm going to put monocryl sutures now.
To keep all the 5 strands together.
Yes, to keep all of them together. What is this? I'll leave it. I've got it on this now. Wait. Yeah. I'm going to put monocryl sutures and I'm going to pre-tension my graft. I think I really believe in the concept of pre-tensioning. So you have this pre-tensioner that comes up here. So you put one. This is broken. This pre-tensioner is broken. Okay, so now we have this. No, this pre-tensioner is broken, Prahlad. This is a broken pretensioner. We can't use this. So unfortunately, we have a broken pretensioner. This is very unfortunate. And I think the company who is providing instruments should look at their armamentarium a lot more properly. And at least for live demos, they should supply proper instrumentation. I think they are the ones who are losing in all of this by doing such unfortunate things. Right. So I'm using the other non-measurable pretensioner in this particular fashion. And now I'm going to ask Ranjit to stitch the entire graft with monocryl from start to end. And after that has been done, he is going to take a Raytech gauze soaked in saline and wrap the graft. Okay.
Sachin,
Yes.
there's a small doubt we have.
Yes.
There is a mismatch between the length of ST and gracilis there, isn't it?
Correct. That is because the ST.
And how are we going to manage that?
So the ST is going to get cut because the ST was quite long, right? So I don't think that is going to come too much in our way. I could have decreased or cut off the ST to match that of the gracilis. But I think I sort of just stitched it. And once our graft protrudes out of the tibia, we will let go or just excise that extra piece of gracilis which is there. This is 70-degree scope. Where is 30-degree scope? Why are you guys giving me 70-degree scope?
Excess semitendinosus, you mean?
The
Excess ST can be.
excess ST I will cut off.
So given a chance, you will prefer to cut ST or gracilis?
Given a chance, I will not cut anything. Given a chance, I will not cut anything.
Yeah.
Camera 2.
A 4-strand semitendinosus gracilis would have been more better here.
You can do that. It will make a very thick graft, Mukesh. It will make a very thick graft because already we are now coming close to about 9. All right.
Yeah.
The patient's footprint is 9.
Okay.
A 4ST with 3G will go to almost 11.
2G.
And if you start a very large graft is also not a very good idea. Light source on is also not a very good idea. Now you'll have to move back up.
I am also of same opinion like you because more than 10 mm graft is very, very big. You have to go for 11 mm screw and it's becomes very non-anatomical then.
Inside view.
So 9 mm is optimal.
Yeah. If you have a very large graft, it starts stuffing the intercondylar notch and then that creates problems. Okay. So now inside view on, I don't want. If they want, they can have. Then let it be. Forget it. Okay. So now we can see some loose cartilage fragments in the joint. I have not made them. So we're looking at the suprapatellar pouch here, going down to the medial recess. Again, coming up, going down now very gently to the lateral recess. Gradually, we are now entering the popliteal hiatus. What you see now is the popliteal hiatus and the tendon of the popliteus that is going right to the back of the knee. The popliteus tendon has 2 popliteomeniscus fascicles. You can see the what happened? You forget the recording, right? Don't forget the recording. You can see the anterior inferior fascicle and you can see the posterior superior fascicles. These are the 2 fascicles of the popliteus. And once you see them, if you internally and externally rotate the knee, you can see the popliteofibular ligament tightening and loosening right in front of you. So whenever you're suspecting a posterolateral columnar injury, that is a good thing to look at and decide what one needs to do. There is some fraying in the trochlea. The patella otherwise looks fine. I'm now going to flex the knee to 70 degrees. Once you flex the knee to 70 degrees, you will come in with a top view, camera 2. Sorry, camera 3. Camera 1, sorry, camera 1. You will come in with a spinal needle and you can observe that the fat pad is like a triangle with the apex at the inferior pole of the patella. So you want to come in with a spinal needle or a standard needle with the knee flexed to 90, and your needle should touch the roof of the intercondylar notch. Leave the needle in place or take it out, and now make your first portal, which is the anteromedial portal. The anteromedial portal is important because if you don't make a proper portal, you will not be able to look down properly. And if you cannot look down properly, you will not have good visibility. Remove this.
Sachin, we are not able to see the arthroscopy pictures.
Inside view, somebody please show it. Do PIP. Do PIP inside view. Okay. Once this is done, you want to resect as much of the fat pad as is required. You don't want to have any compromised visibility. So now I'm coming with a 4-5 shaver under suction, and I'm just cleaning up the fat pad, which is going to obstruct my view. There was some thought previously that, you should save the fat pad. Yes, if you save the fat pad, it does help in causing less infrapatellar scarring. But if because of a large and thick fat pad, you have obscured visibility of the anatomy, and if you make an abnormal or a non-anatomic tunnel, then the chances or the risk of landing in failure are much higher. So if you ask me, I will take the risk of a bit of scarring in the fat pad as against the risk of doing any form of abnormal, as against the risk of having a
I think the scarring risk is very, very minimal. I don't think we should worry too much about that.
Okay, so now this ACL looks so normal that you feel, oh my God, I mean, is this actually a tear? But you probe it, you'll see that it is completely come off from its femoral origin right here. There's nothing here. And this is a lambda healing in which the ACL sticks to the PCL. So this gentleman had a femoral sided avulsion. If you can see, I can just tease off the femoral sided avulsion here, right there. Okay, he's had a femoral sided avulsion, and the whole ACL has stuck down to the PCL. So what are we going to do? We're going to try and preserve as much remnant as possible. With the help of a probe, I'm just going to try and release all of this, which is there. Again, please don't get too overexcited to try and preserve all the tissue, because the worst mistake that you will make is that you will start preserving tissue. And then, because if you have limited visibility, then you will place non-anatomic tunnels and you will have compromised outcomes. So that is my philosophy, or that is my understanding of how to approach such type of injuries. If you want to preserve all the footprint, then you have to have another type of, you have to have some other extra visibility in the form of either using a C-arm or something of that sort to look at it. So this is the ACL now. Where was the arthroscopic ruler? It was somewhere here. I had kept it here. Yeah. You want to measure the length of the footprint. So preoperatively, it was 16 millimeters in length. And yes, it matches 16 millimeters in length. Pretty happy about that. We'll look at the width, or we'll look at the ml dimension of the footprint as well. So let us check that now. And again, I find this ruler to be a very good companion. So here it is 9, okay, 9.5. So if you put in a very large 10 millimeter graft, it is going to remove the tibial spine, which is not a good idea. And if you check the width of the notch, it is barely 10 millimeters. Again, any graft which is larger than 10 will cause stuffing of this intercondylar notch, and your patient is likely to have a flexion contracture. So bigger is always not the best. You need to be exactly appropriate, and that is what we want to be. So now we'll start with palpation.
Sachin, what is your view about anterior-posterior width? You are telling about width in the coronal plane, isn't it? In the sagittal plane. ACL's dimension in the tibial side.
16 is anterior-posterior.
Yeah.
And mediolateral was 9 millimeters.
Okay, fine. Yeah.
Okay.
Thank you.
Thank you. So now you want to see, and the first thing that you want to see is the posterior middle part of the meniscus. So you pass your scope between the MFC and the PCL. The knee is still flexed to 90. You can see the shiny white fibers. These are the shiny white fibers which recognize or which indicate the insertion of the meniscus root and the recess between the root and the PCL. They are fine, so the root is good. And now you slowly walk in the back of the knee and then turn your light source around to see for a ramp lesion. So very nice talk in the morning by Dr. Sujit about ramp, and this is exactly what you want to see. You can, with your knee, just give a bit of varus force. So I'm just giving a bit of varus force with my knee, and that will open up if there is any ramp. Preoperatively, his MR scan was showing the presence of a tear, and now we'll bring the knee to a position of 10 degrees of flexion, pass in a hook probe in between, and start palpating the undersurface. So on palpation of the undersurface, you can see that probably there is, the meniscus looks just fine. You don't want to create a tear by pulling, but here I just feel there's a bit of extra mobility and giving way. And you can see that when I press on the meniscus, you feel that it is sort of, wanting to pout out inferiorly. At this instance, camera number 1, at this instance, I'm going to palpate the posterior middle part of the tibia. Zoom in. Camera 1, zoom in. Camera 1 large, arthroscopy picture small. So you're going to palpate the posterior middle part of the tibia. I'm providing a valgus force with my leg, and I'm going to make a series of micro perforations in the MCL. And as you can appreciate, the MCL will give way. Now inside view large, outside view small. Inside view large, arthroscopy image large. And now you can appreciate that the meniscus, you've done pie crusting of the MCL, so that now you have good access to the medial meniscus. So here I cannot appreciate any medial meniscus tear. The MR scan was showing an intrasubstance signal. I am not too upbeat about trying to remove the zone 3 of the meniscus to observe a tear because it is not communicating. This meniscus looks too nice for me to do anything.
It's a grade 1 tear, isn't it?
Yeah, any difference of opinion? Anybody who would want to take out and start probing and create a tear in the meniscus? Yeah. Since the patient has got some laxity, it is quite normal and natural that you can get, such kind of opening, which is suitable to you. Now we are going to bring the leg to a figure of 4 position. The things that you need to check here are the lateral root of the meniscus, the posterior root of the lateral meniscus. Again, very important. You can very nicely see the posterior root of the lateral meniscus, how it is inserting very nicely on the tibia. And you can then see the entire meniscus in its entirety right down to the anterior horn, which is what you require. In the mid-third area, you can again observe for the popliteus tendon. This is your posterior superior popliteal meniscus fascicle. You will have the anterior inferior, which is best seen when you look at it as you drive it down the gutter. Now there is an abnormal opening on the lateral side here, but this is not a posterolateral columnar lesion. This is because this patient has got hyperlaxity, which is why he has got this kind of appearance. So flex the knee to 90, please now. Prahlad, please flex to 90.
That's what I was thinking. No, lateral side you're opening up quite well. Lateral structures are normal, isn't it?
Lateral structures are normal.
It's due to ligament laxity.
His clinical exam does not suggest the presence of posterolateral columnar injury. He's got hyperlaxity, which is why there is abnormal opening on the lateral side. Next, you want to make an anteromedial portal. Camera 1. Camera 1 large, arthroscopy image small. Okay. This is the area of the joint line, and you want to come in with your needle and direct it towards the proposed site of the tunnel. So this is how you want your needle to come. You want it to be close to the medial femoral condyle, above the meniscus and to be directed in that fashion. Prahlad, please remove the needle, take it out. And now I'll make my anteromedial portal, and I always make it horizontal because I want a good area for my drill to come through. So we're doing an anatomic type of ACL reconstruction where we're doing transportal drilling. And for that reason, we create an horizontal type of a tunnel. I do not cut through the fat pad. Instead, I just open it up with a dissecting medicine bomb type of a scissor in both an anterior-posterior and a medial-lateral fashion, and then just come in with a shaver and clean up a bit, which makes you sort of, tidy up the whole thing so that all your instruments pass through quite easily. At this juncture now, I'm also going to do a bit of cleaning up for my anteromedial portal, because as you flex the knee, the fat pad changes. There'll be a new portion of the fat pad which comes into view. And always, I think it's nice to have surgery which has got good visibility, which then allows you to do a good job. My scope now will shift to the anteromedial portal because we want to see the femoral footprint. Ruler, please.
Now, please show us the femoral tunnel.
Yes, sir.
Yeah.
So now I'm going to take the ruler, and this ruler is going to get bent in this particular fashion, like this. Again, inside view large. And then I'm going to pass this inside view, please. Make the inside view large, outside view small. And now I'm going to pass this ruler in this particular fashion. You want to go and reach the end of the intercondylar notch, and you can see and observe that again the ACL footprint in this gentleman is about 8 to 9 millimeters, right? And the height of this ACL footprint, again, I'm just going to enlarge the portal for a moment so that we can get our ruler in properly. Second, Prahlad. And the height of our ACL foot, oh gosh. Oh, shush. What is this? 1 second, I'll just get a shaver in. We'll just take it out. It will come again. Sundarajan will shout at me. Huh? I don't do a job. Okay. Yeah. So again, if you observe very carefully here, it's roughly around 7, 8. So 8 millimeters is the extent, correct? And if you look at the width, it measures about 12, 11, no, hang on for a second, 11, 12, 12. So 9 by 12 is the femoral side, okay? There are a couple of ways you can use this femoral footprint to your advantage, and we'll go through all the various techniques. I'm just doing a bit of a cleanup here so that you can see it properly. You need to see properly, otherwise, if you don't see properly, you will not have good tunnels. And if you have wrong tunnels, then you have wrong surgery. So, which are the various techniques by virtue of which, where is the meniscus slaughter? This one, meniscus slaughter was there, right?
Sachin, for the sake of audience,
yeah,
can you please show us the ridges that you see, bifurcate ridge,
exactly.
residence ridge?
Yeah, I'll go through everything. Come
Yeah.
on, then. Subi, hold this. Right. So now, what are the ways in which you can mark your ACL tunnels? Method 1, give me a trimmer. Hold this. Put gauze piece and soap. Give me a trimmer, Prahlad, from here. Just give me a trimmer in my hand. Yeah. So technique 1. Take out your slotted cannula. Technique 1. When I see the footprint, I place my reamer, which is equivalent to the diameter of the tunnel that I'm going to drill. I match it exactly on the footprint and I drill through it. Technique number 1. When you see the whole footprint properly, this I feel is one of the best ways to do it. Technique 2. use a ruler. So in this, hold the scope, Prahlad, please. Hold the scope properly. Yeah? You should show it properly. Otherwise, they will remove you from Tamil Nadu Arthroscopy Society. Wait. They will remove you, Prahlad. Okay. Technique 2, if you can see, if you are able to visualize the footprint properly, hold the ruler. Prahlad, you want to hold the scope or the ruler? You will have to hold something. Yeah, the ruler should not shift. Okay. Where is the tocha? Technique 2, you want to align the ruler with the posterior most border of the footprint. Prahlad, right there. You want to measure the length of the footprint, and then Prahlad, don't shift the ruler, beta. So this is the posterior border. Just hold the tocha 1 second. There is some tissue which needs to come out. Better. Yeah, it was coming in the way. Okay. So you align the ruler with the posterior most border of the footprint. Prahlad, don't shift the ruler. Take it, pull it out a little bit. Prahlad, they'll remove you from Tamil Nadu Orthopedic Society, Arthroscopy Society. Don't do that. And now you can see that the footprint measures about 10 millimeters. If you want to do a center to center, go to 5, but I will go to a 4, and I will make do tutu, and I will make do tutu. Dona, go. Subha, Somi, bas. You will make your, take it out, Prahlad. You will make this microfracture all whole, which will, wait, don't do anything. And this will be where you will make your tunnel. So this is technique 2. Technique 3, keep this like this, Ray. Technique 3 is that you will take an offset aimer. You will take an offset aimer, which comes from behind, and you will go there. But I find this very crude because this offset aimer, you have so many offset aimers, and it's not that all the offset aimers are properly oriented. So offset aimer is technique 3. Technique 4 is you can completely denude the footprint, and I'll do this here now, so that you take out all the soft tissue from the footprint by using a radio frequency, by using a curette, by using whatever technique you want to use in this particular fashion. And then you palpate and see all the ridges which are there. So I need a small curette, Ray. You had a small curette, Ray, please. So in cases of chronic acyl instability, where you have, 1 second, Prahlad, where you have no